Everyone, let me say hello and thank you for tuning in tonight or eventually watching this, and I hope you really enjoy it. Like Jeff said, we had 4 sessions, and I've truly enjoyed all of them. We started off talking about the heart. We talked about CHF and all these updates. We talked about stress testing. We talked about rheum and endo, focusing on the adrenal gland, and of course, talking some, really tough cases in rheumatology about using biologics. Then we had the gallbladder, which was one of my favorites. Who gets to get the chance to talk about the gallbladder? You know what I mean? Then we went to the kidney after that and talked about the importance about diabetes in the kidney. And, for the last one, I couldn't help but go to my, my specialty, which is always going to be the lungs. And I was thinking about, what do I want to talk about? So when I was looking at the ABIM, and they recently just came out with a new blueprints about what are going to be some of the changes out there, they really do focus on obstructive lung diseases, and there were some updates. And when we talk about updates, we're always referencing guidelines. What is my take-home message when someone says, well, have you heard this definition or this workup? It's the guidelines. I always encourage saying, well, whose guidelines are you talking about? And that's why I put the word sneaky updates over here, because these updates kind of just creep in there, because whose guidelines are you referring to? And definitely when we talk about the internal medicine board exams, it is definitely fair game for them to quote a specific guideline. And I've seen this all the time when we talk about cardiology, when they talk about lipid management, they're quoting specific people, the American College of Cardiology, So I do want to bring up some of the things that have changed a little bit in asthma and COPD. Is it 100% guaranteed that this will make your board exams? It's hard to say. Usually when guidelines change, what do we say? It's around that 1 to 2 years in between, but I think it's good to know these things in general. So, and there's gonna be a lot of core things I guarantee will be on your board exams. So we are going to focus on obstructive lung disease, which is going to be all green. So when you look at the ABIM blueprints, there are things that are going to be in green, things are going to be like in a gold yellow, and things are just going to be in red. And the green stuff is going to be the big chunk of it. So asthma and COPD are huge when we talk about, glowing green for the ABIM boards. So for asthma, I'm going to talk about something called SMART therapy. I want to talk about the role of an asthma control test, something called exhaled nitric oxide, a little update in leukotriene inhibitors, and this last biologic. And the thing I hate about biologics, I just can't pronounce any of them. So you can make fun of me if I just totally hack this one up. But this is tezepelumab. If someone can pronounce it better, all the power to you. So this is one of the newer biologics, and I want to talk a little bit about that. Then we're going to go to COPD. There are some new gold guidelines, something called the ABE assessment, which is going to replace the ABCD combined assessment. We're going to talk about the initial COPD pharmacological management, and not to steal my own thunder, but dual long-acting bronchodilators are becoming more and more prevalent and using them more upfront in the management of chronic COPD. And I got to talk about triple drug therapy. And I know that every subspecialty has their own idea of what triple drug is. In the COPD world, it's going to be that combination of a LABA, long-acting beta-2 agonist, LAMA, long-acting antimuscarinic, and last will be ICS, inhaled corticosteroid. And what is the role of this triple drug therapy? So let's use some asthma updates and some board pearls. So I think the biggest one out there is that, the role of the quick relief inhaler. And don't get me wrong, when I trained, I was all about being told that, if you have something called mild intermittent asthma, you definitely need to, avoid those triggers, and you got to have that SABA, short-acting beta-2 agonist, to get those pups in there, your albuterol. But, times have changed, and guidelines are fighting other guidelines, because now, certain guidelines are not even acknowledging something called mild intermittent asthma. And on top of that, they don't want you puffing away with your short-acting beta-2 agonist by itself without combining it with an inhaled corticosteroid. And who's causing all this strife and anger? And I'm just joking. I mean, they're not really in fighting, but two opposite viewpoints are one called the GINA and something called the NAEPP. So GINA is the global initiative for asthma. And of course, that deals with the world. And here in the United States, we focus on the National Asthma Education Prevention Program. And they have two viewpoints about the terminology of mild intermittent asthma and the role of just giving a SABA by itself or combining SABA with an inhaled corticosteroid anytime you need it as needed. So that's what this first slide is here. Sure, all patients with asthma should be provided with a quick relief inhaler, but what should that be? Should it be a SABA by itself or SABA combined with an ICS? Sure, SABAs are what? Bronchodilators. That's what they do. They help dilate, hopefully reverse bronchospasm, hopefully give you better airflow going in and out. But new safety information suggests that they should only SABA be used when combined with an inhaled, glucocorticoid steroid. And why is that? Well, when I think of asthma, right? What are the particles that damage the lungs in asthma? They're sensitizing particles. They rev up your immune system. So of course, when you talk about your immune system, you think about what? Immunosuppressants, and you think about what? Inhaled steroids. So that's the big debate right now. Should you just use a SABA or a SABA combined with an inhaled corticosteroid? So these are the two groups right here. We're going to talk about GINA first. That's the Global Initiative of Asthma. So they recommend that all adults and adolescents with asthma should receive an inhaled glucocorticoid combination with a SABA to reduce the risk of exacerbations and to help control symptoms. And this recommendation of combining a SABA with an ICS is for any level. Notice it's bolded red of asthma severity, which includes what? Mild intermittent asthma, which I don't even like that term anymore. And they'll use this combination of a SABA ICS for maintenance therapy. So even if you need a couple puffs here and there, you'd use it, and definitely for rescue therapy. And of course, a lot of the studies here were going to be a glucocorticoid combined with a LABA, which is in this case formoterol. And just to give some brand names out here, the one brand name of a LABA ICS was Symbicort. But the whole take-home message was combining a glucocorticoid with a beta-2 agonist. Initially, the studies were done with LABAs and ICS, but I'll let you know that down the pipeline, in fact, something that was already FDA approved, are a SABA short-acting with an ICS. And right here, for mild asthma, use that inhaled glucocorticoid combination with a beta-2 agonist as needed, or anytime that you need a SABA, you got to combine it with a glucocorticoid. So that's what GINA says. Now, what about the National Asthma Education Prevention Program, the NAEPP? So they still recommend that, hey, it's okay to use a short-acting beta-2 agonist, and there is something called mild intermittent asthma, which we are defining as having symptoms fewer than 2 days per week. So their whole defense of why it's still okay to give a SABA is because they feel that GINA's recommendations were extrapolated from data suggesting that even those with mild intermittent asthma can experience serious morbidity from asthma, and that ICS use reduces asthma deaths and morbidity. And what they're saying is that they got this recommendation from the mild persistent asthma and kind of carried it over to the mild intermittent. That's why they said, however, large-scale trials have not been conducted on this mild intermittent population, which is the largest group of asthmatics in the US, which is totally true. So if you're giving all these mild intermittent people, which is the biggest chunk, inhaled corticosteroids, these patients really have not been examined to the side effects of having lots of inhaled corticosteroid exposures. So that's a very good rebuttal. So, when we think about the two, think about the National Asthma Education Program, still pro mild intermittent and okay giving SABA, back here to GINA saying no, anytime you need a maintenance, anytime you need a quick relief, it has to be an inhaled corticosteroid combined with a beta-2 agonist, whether that's going to be a long-acting or short-acting. So what about short-acting anticholinergics? I just thought it would be nice to put that there, So short-acting anticholinergics, the classic one is what? Ipratropium, which is brand name Atrovent, are definitely less effective than SABAs in relieving acute bronchospasm in asthmatics, but they may be used as adjunctive therapy to SABA treatment in the management of acute exacerbations. So when you go to an ER, of course, when you're getting those nebulized therapies, they usually combine it with a albuterol and an ipratropium combination. The combination definitely has been shown to reduce hospital admission. So I'm all pro that. But I also want to talk about long-acting. So long-acting, anticholinergics, are definitely listed as appropriate therapy in both the GINA and NAEPP guidelines after an inhaled corticosteroid and a long-acting beta agonist. But it's important to realize that LAMAs, are not an alternative to LABA unless there's a contraindication of giving a long-acting beta-2 agonist. And, with that being said, there's definitely going to be medications out there, and I'll just throw it out there, something called Trelegy, and every time we think of Trelegy, which is the LABA, LAMA, ICS combo, I think we talk a lot about that for COPD. It was also FDA approved for asthma. So we've used, LAMAs in asthma quite frequently. Tiotropium, which goes by the brand name Spiriva, also got FDA approval for asthma. So this is not new. So definitely there's a role for short acting in the acute sense, and LAMAs definitely have been FDA approved for asthma, not as an alternative to a LABA, but can be added on, or if there's contraindications of using a LABA. So GINA and SMART therapy. Why? So, SMART therapy stands for single maintenance and reliever treatment. GINA no longer recommends SABA-only treatment. Why? Because SABA-only treatment, they feel increase the risk of severe exacerbations. Their mentality is that, hey, asthma is all about sensitizing particles, revving up the immune system. We definitely need to have that anti-inflammatory component on. There's definitely evidence-based medicine supporting GINA and SMART therapy. There was a SMART dosing in systematic review and meta-analysis, and one of the titles was the evaluation of budesonide formoterol for maintenance and reliever therapy among patients with poorly controlled asthma. There was a SIGMA trial, SYGMA, which was Symbicort, brand name, given as needed in mild asthma. There was the ASSIST trial, ASIST, which asthma symptoms-based adjunct in inhaled steroid therapy, and this was focusing on African-American children. So they definitely had some evidence behind, GINA's recommendations. So SMART therapy, why no more albuterol alone? Let me just give you some of the science and the clinical behind this. They just said that, hey, if you just be puffing away with beta-2 agonists, you're going to get beta receptor downregulation. You're going to get decreased bronchial protection from the beta-2 by itself, rebound hyperresponsiveness. You're going to get increased allergic responses. And they found out through their studies that, hey, if you have greater than 2 canisters of albuterol per year, that equals a higher number of ED visits, emergency department visits. And if you're doing greater than 12 canisters a year of the albuterol, there's a high risk of death. So I put this here because there's definitely different beta receptors in the body. There's beta 1, beta 2, and there's even beta 3. Usually we focus on beta 1 and 2. So I put this little box down here. So if, any med students kind of creeped in on this lecture, remember beta 1 is for heart because you have only one heart, and beta 2 is for lungs because we got 2 lungs. I don't know. I thought that was really cool, and I hope a med student kind of likes that. So SMART therapy, what does it mean? So let's talk about these bullet points before the picture. So, what it does mean is that we're going to change the thinking about appropriate medications for asthma management. I know there's a lot of questions about that. I know right now when you want to give, insurance-wise, the ICS LABA combo, like, a Symbicort, you're definitely not going to get the approval by insurance for not only keeping it as your maintenance, but use it as an as needed. They're going to run out. So that's been a big thing. So, but it's definitely a change in how we do things. And of course, you can get around this by ordering a separate inhaled corticosteroid in your albuterol, but who knows if they're going to cover that. And I like the second bullet point, which is, the dogma of albuterol for reliever by itself. It's so yesterday. And so when I thought of that, that phrase, I thought of this movie over here, which is, I don't know if anyone knows, I'm a big movie buff. Does anyone know what movie this is? This is Alicia Silverstone playing Cher in the movie Clueless. So I kind of aged myself. But that movie kind of makes me laugh. And I can see her kind of talking about smart and Gina therapy up there, saying it's so yesterday, and so of course you have to update your asthma action plans. And, these changes by adding an inhaled corticosteroid to your beta-2 agonist will hopefully give you better overall control of your asthma, less ED visits, and reduce the amount and severity of exacerbations. So with that being said, I mentioned, you have to change your asthma action plan. And I just wanted to mention that I hope most of us, I know I could do a better job with that, provide your patient with, here's an example of an asthma action plan. It clarifies your medication regimen. It helps patients to identify declines in asthma control, whether based upon symptoms or peak expiratory flow. And it helps guide treatment adjustments in response to a change in symptoms, So all these are things that hopefully you could speak with your patient. If they're doing good, continue your meds. If they're having a yellow or red day, here are going to be the next steps. So I put this under the title Beyond the Pearls because it's not easy to get this yet, because during the beginning of this talk, I was talking about combining an ICS with a short-acting beta-2 agonist. And everyone's like, hey, where do I get this? So just to let you know, the combination of albuterol and budesonide has now been approved by the FDA for as-needed therapy in patients greater than 18 years of age. Unfortunately, it won't be widely available until early 2024. Here's the brand name, Air Supra. I don't know if I like that name. Let me know if you like that name. But anyways, and here's the New England Journal of Medicine article called Albuterol Budesonide Fixed Dose Combination Rescue Inhaler, which really helped get the approval for the medication. So this is the trend in where medicine is going, so I'm glad we're talking about this. So let's do a question. 34-year-old dude is evaluated at a routine follow-up examination. He has a history of spirometry-confirmed asthma. He reports feeling well and denies sinus symptoms, GERD, and tobacco use. He demonstrates excellent inhaler technique. Meds are inhaled, budesonide and albuterol. On exam, vitals are normal, and the remainder of the examination is unremarkable. Which of the following is the most appropriate next step in evaluation? Should we administer an asthma control test? What is that? Should we measure fractional exhaled nitric oxide in this patient? Should we go for the PA and lateral chest x-ray? And should we perform a 6-minute walk? It seems like, this patient is doing well. He doesn't have any other symptoms. Here's his med. So I don't really think it's necessary to say, hey, let's get a chest x-ray for the sake of getting one. I don't think we need a baseline right now or anything like that. 6-minute walk, it's never wrong to get one. It just gives you information, but I don't feel in this young 34-year-old a 6-minute walk would be the next thing I'm going to order in this patient. It really comes down to, am I going to do something called the asthma control test to get a more baseline of where this patient is? I think that's not that bad idea. Or should we measure this exhaled nitric oxide? Exhaled nitric oxide really for more, allergic asthma, really not the standard of what we do. It's not wrong to get one. Sometimes use it more for diagnosis and see how they respond to therapy. But just to get a random one, there are so many things that could factor into it. I don't think I would do that. I think the best thing here is to do an asthma control test to kind of get that nice, more subjective and objective baseline. So the answer is A. So literally, this is an asthma control test here, and it just tells you that, hey, in the past 4 weeks, how much of the time did your asthma keep you from getting as much done at work, school, or at home? Then you answer these questions. There are going to be all these questions that take place in the past 4 weeks, and a score that's going to be, 19 or less means your patient's asthma may not be controlled. So it's an assessment. I think it's an essential component of asthma management. It uses a standardized validated questionnaire, which is the ACT, asthma control test. The FeNO is not really recommended to guide asthma treatment in the general population, which is one of the reasons why that was the wrong answer. The asthma control test is a numerical asthma control tools, which are more sensitive to change in symptoms than more of a categorical tool. It's a numerical tool, so you have a really set number right there. And, the higher the score indicates the better the asthma control. So this is a picture of me blowing into nitric oxide FeNO, but exhaled nitric oxide test, it's really recommended as an adjunct measure. The test, it's pretty quick. It takes about 5 minutes, and it's very similar to spirometry. Really, I have wonderful respiratory therapists. They help, they help guide you as you do the steps. So basically, pretty much, I didn't put the clip on my nose, but you put a clip on your nose, you exhale completely till your lungs are empty. Then you put the mouthpiece in your mouth. That's what I'm doing right here, and I inhale slowly. Then you exhale slowly and steadily until you hear a beep or a light comes on. And down here is the monitor, and I had to keep this kind of balloon inside these two lines there so I could have a steady blowout. And I may need to repeat the test, but it's much, it's quick. You can use it to help, with people who have allergic asthma. The whole thought process is that if you have a lot of eosinophils in the airway, they make a lot of nitric oxide. But unfortunately, it's just not standardized just yet. So what about this? 24-year-old woman is seen in follow-up exam for asthma, diagnosed 4 months ago. She reports that her symptoms are now well controlled without the use of her rescue inhaler, and results of the asthma control test, all right, isn't it good we just did this, confirms well-controlled asthma, so it's probably at a very high number on the exam, on the test. During the visit, she describes feeling down on many days with difficulty falling asleep and early morning awakening. So they do a depression screening with the patient health questionnaire called the PHQ-2, and it's positive. Meds are beclomethasone, montelukast, and albuterol. On exam, vitals and pulmonary exam are really unremarkable. Which of the following is the most appropriate treatment? So we have a positive depression score. We have an asthmatic doing well. Asthma control test is good. Should we start sertraline, which is Zoloft for depression? Does this patient need tiotropium and that long-acting anticholinergic? I'd probably say no. Why? The patient's doing well. Why add more meds? Should we stop the beclomethasone and start a combination with a LABA? That doesn't make a lot of sense to me. Number one, patient's doing well on his current asthma therapy. Should we stop the montelukast? All right. Why? Should we add Xylutin, which is another leukotriene type inhibitor? It's a synthesis inhibitor, and I think I would be combining, that with montelukast. I'm not going to say E, so I guess the ones that make sense would be, well, do we start an antidepressant, an SSRI, sertraline, or stop the montelukast? And I really feel this one will be on the boards. The answer is stop the montelukast. So up here, I put the PHQ-2 screening questionnaire. The good thing about it is there's only 2 questions, which is nice. And why did I put this here is because, montelukast should be discontinued in patients with symptoms suggestive of depression. I put that in bolded red. So in March of 2020, the FDA added a box warning to montelukast about behavior and mood-related changes, including suicide, and it was associated with montelukast. So I thought it was very important, and I do put the bottom over here, hey, many physicians, including myself, were unaware about montelukast's potential adverse mental health effects. So I really feel this is going to be on your boards. And I wanted to put something about a leukotriene pathway. So leukotrienes, definitely make more mucus in you, so you want to block them. They cause bronchoconstriction. You want to block them. Xylutin goes by the brand name Zyflo. We really don't use that much here in the U.S. It's a leukotriene synthesis inhibitor. Montelukast, brand name Singulair, 10 milligrams taken at night. It's a receptor antagonist, and that's the one that we commonly do use in the United States. But now we know to be careful with people with depression. So with that being said, let's talk about the 50-year-old man is referred for poorly controlled asthma. Triggers include exposure to dust, pet dander, and pollen. He has allergic rhinitis and has been treated with several courses of oral glucocorticoids, but after he stopped treatment, his symptoms, recurred despite regular use of fluticasone and salmeterol, which brand name is Advair, and he's on a LAMA, which is tiotropium, brand name Spiriva. His only other med is albuterol. His inhaler technique is good. It's always great to look at inhaler technique. On exam, vitals are normal, BMI is 24. Pulmonary exam reveals expiratory wheezes. Otherwise, the remainder of the exam is unremarkable. Labs reveal a total IgE level, which is normal, and a CBC without differential, which is normal. They got chest x-ray, that was normal. Spirometry demonstrates moderate airflow obstruction that improves with bronchodilators. Which of the following is the most appropriate diagnostic test to perform next? So let's do this one. So getting like a CBC with diff, to check out if there's going to be eosinophilia. I like that. What I see here, someone on triple inhaler therapy, ICS, LABA, is still having symptoms. It sounds like he's having allergies, sounds like allergic asthma, and he would be someone I would consider for biologics. And when I think about biologics, I think that see if he has an elevated absolute eosinophil count is a good answer. B, this is not sounding like alpha-1 antitrypsin. And for the board, just give me some liver problems, give me some skin problems, give me some emphysema, predominantly in the lower lobes. I don't think it's alpha-1. Aspergillus IgE, so we're thinking more of that ABPA type diagnosis, acute bronchopulmonary aspergillosis. I'm not feeling it in this particular case. Measurement of common allergen-specific IgE. That's not a bad answer to do. You know what I mean? I would like to have, a total elevated IgE before doing that, but with the total IgE being normal, I don't think it's going to be helpful in using medications that block IgE if, specific allergens are positive. It's not a bad answer. And the whole take-home message also with that is just because it's positive on the panel doesn't mean that's your allergen. Just because it's negative doesn't mean it's not your allergen. And PANC, I think we're going to a vasculitis. The one that's associated with asthma would be, things like a formerly known as Churg-Strauss, which goes by EGPA, eosinophilic granulomatosis polyangiitis. I don't feel this patient has any types of small vessel vasculitis here. I think the simplest thing to do, especially given the normal total IgE, is to get what? Get that CBC with diff this time. I would pick what? A. That's great. So let's talk about some of these biologics. I really do want to spend some time with that. So when we talk about asthma, of course, we got to go back to some basic immunology. And I know we only have an hour. I do have a clock. I see it. So when we talk about, immunology, what are going to be some important cells for asthma? Of course, the mast cells releasing histamine and tryptase. Eosinophils really going to be one of the targets that we want to single up is all the inflammation in the airways predominantly in asthmatics are caused by eosinophils. Macrophages are antigen presenting cells. They present the antigen to our immune system. And of course, when we talk about the lymphocytes, we think about the T lymphocytes and the B lymphocytes. B lymphocytes turn into plasma cells that make antibodies. Of course, we're focusing on IgE. And T lymphocytes, of course, we're focusing on what? The CD4 cells, the T helper cells, and there are different pathways. But the T helper cell 2 pathway is very important in allergic asthma. So this is just saying there are two types of ways two types or two parts. I think parts is a better word than types of our immune system, the innate and the adaptive. So the innate are things in contact with the environment. Many of us think of skin and GI tract, but remember our lungs, our alveoli are in contact with the environment. Those macrophages in our alveoli are in contact with the environment. And the adaptive, of course, when we talk about, more of those lymphocytes. And of course, we talk about T cells and B cells. We talked about those. And of course, there's such an overlap between the innate and adaptive immune system. So one of the terminologies we like when we talk about asthma, especially allergic asthma, we talk about the Th2 pathway. So I just wanted to mention that Th2 is T helper cell 2 pathways. It's associated with 3 main interleukins, which is IL-5, IL-4, and IL-13. And of course, we have medications that are going to interact with these and block these. And in the non-allergic pathway, you think of things like maybe the Th1 pathway. And another little important thing I put down there is, since we're talking about our immune system, we talk about T cells and B cells. I always want to give a throwback to my medical students that both T and B cells originate in the bone marrow, but only B cells mature in the bone marrow, and T cells migrate to the thymus. So think B for bone marrow and T for thymus. I hope some medical student just loves that and scores high on their USMLE step 1. So this is going to be when we try to integrate the Th2 pathway in allergic asthma with some of the biologics out there. So when we use biologics, everyone, I could say it 1,000 times, but when do we use it for allergic asthma? Though one new biologic got approved for both allergic and non-allergic, but essentially for allergic asthma, refractory to traditional medical therapy. And yeah, they probably failed things like a LABA ICS or probably a LABA ICS LAMA. Then you would consider using one of these biologics. And of course, there are some very fine points about when you use very specific biologics for certain diseases. So when we talk about IgE, which is going to be the antibody made from our wonderful plasma cells, that we have a drug called omalizumab that blocks that. We have a lot of IL-5 blockers over here, though the ones that we usually use are the top 2, mepolizumab, which goes by the brand name Nucala, and benralizumab goes by the brand name Faserna. Then we have an IL-4/13 blocker combined, and that goes by the brand name Dupixent. Generic name is dupilumab. Man, I'm getting all mapped out with all these different biologics. And of course, IL-4 and 13 will directly affect the airway, but all of them, 4, 5, and 13, all affect what? The eosinophil, which causes all the inflammation in the airways of our allergic asthmatics. So I thought this was nice, you know what I mean? So this is the biologics for obstructive lung disease. Someone's like, old? What do you mean old? Obstructive lung disease. So of course we're focusing only on asthma now. But what do we have? We have our IgE blocker, omalizumab, IL-5 blockers. We mentioned the big 3 out there. We'll have one more slide about it. IL-4/13, which is Dupixent. And the newest one on the block is going to be blocking thymic stromal lipoprotein, TSLP, which got approved for both allergic and non-allergic asthma. So let me just show a couple more slides before we switch gears and start talking about COPD. I know that half an hour went by pretty quick. So here is Xolair, probably one of the first biologics for asthma that came out there. Think about it for people with moderate to severe allergic asthma, refractory traditional medical therapy, and of course, they've got to have an elevated IgE level. You dose the omalizumab based upon weight and IgE level. You base on both. We definitely use omalizumab in pediatric patients. It got approval for people 6 years of age and older. I think many of us, kind of remember you need to carry that EpiPen. And the big thing about this is that when you get the first 2 shots, you do it in the healthcare setting. And if you tolerate the medication and there's no problems or side effects, you can start injecting at home, because this was such a big limiting thing on this med, was having to always inject it in a healthcare setting. So think about omalizumab. Now, if you don't have an elevated IgE and you have moderate to severe persistent allergic asthma and you have elevated eosinophils, like we did in that question, you could consider using an IL-5 blocker. And so I put all the brand names there, Nucala, Faserna, and Sincair. The one we pretty much don't use is Sincair. Goes by the generic name Rezolizumab because it's given through the IV. It's just not convenient. But if you fail one interleukin-5 inhibitor, doesn't mean you failed the whole class. You could, if you fail brand name Nucala, then try brand name Faserna. So you could kind of go between the class itself. And here is going to be our friend mepolizumab. What a surprise. Inhibits IL-5 that directly affects eosinophils that will help out with inflammation. All mepolizumab and the next one, which is going to be benralizumab, both can be injected at home, which is huge. And here's benralizumab, Faserna. Of all the biologics I just mentioned, which includes Nucala, Xolair, and Dupixent, it really has the least amount of doses that you have to inject per year, which is 8 injections, which is pretty nice. And as I just mentioned, you could do this at home. Sincair is an IV infusion, which kind of makes it very unpractical. You must really want to give an IL-5 inhibitor, and they failed the other two to want to give someone resilizumab. Dupixent, we both know, all of us know they have great commercials. Dupixent is for moderate to severe allergic asthma, refractory to traditional medical therapy, probably not with an elevated IgE. You can use this if you have elevated eosinophils, but it also got FDA approval if you're really stuck on steroids, And all these medications are good as steroid-sparing agents, but it so happened to get an approval for it if you're on steroids to reduce the steroids. And it also is used for atopic dermatitis. If you're taking your GI boards, it got FDA approval for eosinophilic esophagitis. And yeah, you self-inject it every 2 weeks. Probably one of the first ones out there with home injections, which was great. And it's an IL-4/13 inhibitor. And the last one I wanted to mention is tezepelumab. And this is going to be a medication. I believe the brand name is Tezspire, but don't quote me on that. It's first in class. It binds to thymic stromal lipoprotein, which is a really, really upstream regulator. See how it's really upstream over here? And what's going to be downstream to this? Inhibiting things like IL-5, IL-4/13, blocking IgE. And because it's so high up there, it got FDA approval for both allergic and non-allergic asthma. So, and why is this important? There is a procedure called bronchial thermoplasty. It's been around for more than 10 years, very barbaric. And, when do we use this procedure is kind of when you have the intrinsic non-allergic, non-atopic asthma, because there's no biologics for it. But now that this drug is out there and it got the FDA approval for non-allergic asthma, I really don't even know what the role for, the procedure bronchial thermoplasty would be. You really must have to fail everything to even do that procedure. So this was kind of nice to have this medication out there. So, with our remaining time, and I am looking at my watch over here, my phone, let's talk about COP updates and some board pearls, okay? So I put this here because when we talk about COPD, I feel like my opening statement is always don't smoke. And I do mean that, don't smoke. Smoking could affect almost every single organ in the body. But, there are other things that cause COPD. Whether it's going to be talking about infections, whether it's talking about pollution, whether it's talking about reactive oxygen species, are all damaging the airway epithelium. And there are certain cells that are more associated with COPD, emphysema, chronic bronchitis than not. Some of these cells are going to be including things like, our neutrophils. Sort of a lot of neutrophils over here. Definitely a bigger role for CD8 cells. When we talk about asthma, we really spent more time on CD4. And, when we talk about COPD, there are associations with asthma. So it's not surprising that in certain patients with COPD, you could see eosinophils. It's also not surprising people with COPD can develop fibrosis, where as scary as it may be, you'll see emphysema at the apices of a CT image, and then on the basis, you'll see honeycombing get fibrosis. So people with COPD, they do have these fibroblastic foci that results in fibrosis in the lungs sometimes. So there's definitely a lot of pathways when we talk about the final damage in the lung that happens in patients with COPD. I put this here because, there's this asthma COPD overlap, and specifically, I know when people call it overlap syndrome, and the big, question is asthma COPD overlap a unique disease? And it's still the jury's out. I think that, does it really change your clinical management? No. But we just call it asthma COPD overlap. And to overly simplify it, what do I say when people ask, how can someone have both? Well, trust me, it's scary as it is. There are people with asthma that smoke, and there are people with COPD that have allergies. So it doesn't surprise me one bit. So, of course, in the asthmatic, I thought this was a nice image showing the role of the eosinophils and IgE over here. But, of course, they can have cigarette smoke attacking them, too. Now, on this side, COPD, you could see the neutrophils and CD8 cells. And, of course, they can get what? Allergies. So that I just thought it was a nice picture to show about that overlap. So let's do a question. So we have a 58-year-old man is evaluated for chronic cough. He has some occasional wheezing and shortness of breath associated with frequent stops to catch his breath. when walking around 1 to 2 blocks on level ground. His medical history is notable for episodes of bronchitis, for which he underwent outpatient treatment 6 months ago. All right. He's a current smoker with a 30-pack year history. On exam, vitals are normal. Examination of the lungs show mildly decreased breath sounds throughout both lung fields and occasional scattered expiratory wheezes. The remainder of the exam is normal. Spirometry shows an FEV1 of 70% predicted and a post-bronchodilator FEV1 FVC ratio of 62%. His modified MMRC, Medical Research Council symptom score, is 2, in addition to smoking cessation, which the following is the most appropriate management. So, I think there's a bunch of different things here. This is going to be a question to help me start talking about GOLD classifications and how do you classify people based upon symptoms and exacerbations, as well as spirometry. So I do put this here purposely because, when we talk about diagnosing COPD, this is a little more detailed than for the internal medicine boards, but we do like the post-bronchodilator FEV1 FVC ratio. Not the the post, but on the IM boards, you're not going to focus on that. And the ratio is 62% of predicted, so it's less than 70, so the patient definitely has obstructive lung disease. FEV1 is 70% of predicted. So when we talk about severity, stage 1, GOLD stage 1 will be 80 and above. 50 to 80 is moderate, so he is moderate. And based upon this scoring system, the MMRC, which you have to memorize, which stinks, you know what I mean? Any score that's 2 or above, puts you at letter B. B as in boy. So this is kind of a 2B. So what would you do with this patient? Would you do a combination of an inhaled glucocorticoid and a long-acting bronchodilator? Does this patient need an inhaled glucocorticoid? It doesn't really sound that way just yet, so I wouldn't say inhaled glucocorticoid. Is he having repeated exacerbations where you want to use a phosphodiesterase inhibitor, something, that is an oral medication when we talk about COPD that will kind of help prevent exacerbations? This is going to be mainly for people with more of the chronic bronchitis type phenotype when we talk about these oral phosphodiesterase inhibitors. And so I think that would be wrong just by itself. And even if you combine it with an inhaled glucocorticoid and long-acting bronchodilator, I don't think we need to add the inhaled glucocorticoid here. Short-acting bronchodilator PRN and dual long-acting bronchodilators. Ooh, very tempting. And pulmonary rehab. No steroid here. Everyone loves pulmonary rehab. Short-acting bronchodilator and dual long-acting, so probably a llama-llama combo. That seems really good. I like that one quite a bit. C, short-acting and an as-needed inhaled glucocorticoid. No, that's not going to happen there. So I would say of the choices here, I would probably pick choice C. And if people are wondering, what is this phosphodiesterase inhibitor? What's the brand name for that? We call that Daliresp. And it goes by the generic name Roflumilast. I know everyone's like, well, what is this drug he's talking about? And that got approval for to help out with recurrent exacerbations of COPD. So the answer here is C. So what is the big thing? I want to talk about the GOLD 2023 guidelines. And the big thing with these guidelines is really aggressive use of dual long-acting bronchodilators. So that was part of the answer, as well as pulmonary rehab, which is always a good choice. And using a short-acting there, that was the best combinations of all the things that was picked. So let me go through how do you rate severity. I think most of us are familiar with the classic one-dimensional GOLD spirometry stages, which basically says diagnosing COPD is the post-bronchodilator FEV1 FVC ratio less than 70% predicted, and you memorize the FEV1 for prognosis. And as far as severity, if the FEV1 is greater than 80%, you think of mild, call it mild. 50 to 80 is moderate. FEV1 of 30 to 50 is severe. FEV1 less than 30% is very severe. And we did have some recommendations only based upon spirometry in the olden days. And of course, if it was mild, it was all about just using a short-acting bronchodilator. If it was moderate, just one long-acting bronchodilator. And then as you proceed to severe, well, depending on how severe you are, if you're severe controlled, well, maybe not an inhaled steroid, but if you're severe and still having exacerbations, then definitely you think about an inhaled glucocorticoid. And the reason why things have changed and we just don't use severity is because clinically, I think many of us have patients where their FEV1 is great, but they have a lot of symptoms, or the FEV1 is very poor and they have no symptoms. So that's where these symptoms questionnaire kicks in. So we started using a combined assessment. So we used a GOLD based upon the FEV1 to talk about GOLD stage 1, 2, or 3, or 4. Then we do a combined assessment of a questionnaire. The two questionnaires we use are the MMRC, and the other one's called the CAT, the CAT. And then the other thing we asked about was exacerbations, because we really, really, really want to avoid people with COPD from getting exacerbations. And based upon your questionnaire, the MMRC and the CAT, and talking about exacerbations, we gave you a letter, and the letters were A, B, C, D. A being the best, D being the worst. But things have changed. So here's the MMRC dyspnea scale. It goes from 0 to 4 over here, and they ask you some questions. A score above 2 is going to be relevant. Here's the CAT, which stands for COPD Assessment Test. It's kind of a longer test. The score goes from 0 to 40. Anything above 10 is relevant. And this is the new guidelines. The new guidelines for 2023, we don't call it the ABCD anymore. It's called the ABE. So the E just stands for what? Exacerbations. So if you look at this square right here, it's not going to be like before where it's going to be A, B, C, D, E. That just make up E. A, B, C, D. It's just going to be now A, B, E. E is exacerbations. A, B, and E. So how do I kind of go through this flow? Let's start off on the top left. What do you do first? You do spirometry. We confirm the diagnosis. Post-bronchodilator, FE1, FEC less than 70% predicted. We assess how bad their airflow is based on the FEV1, and that's what we have right below it, where it's GOLD stage 1 is going to be above 80, GOLD stage 2, 50 to 79. I don't want to go through this again, but that's how you get the number. And then you're going to ask about symptoms. Symptoms are based on questionnaires, whether you use the MMRC or the CAT, and really the one, if the MMRC is above a score of 2 or the CAT above 10, that's going to be more relevant, so you go to this letter B. And of course, the big thing is exacerbations. So if someone has, 2 or more exacerbations or just one leading to hospitalization, you go right here, letter E. There's no more C and D. You go right to letter E up here, okay? So this is going to be our new way to assess patients. It's supposed to be easier. It's kind of easier. So it's A, B, and E. E's me, people having lots of exacerbations, just one leading to hospitalization. So I want to go through a couple things. I know the time is getting close again. I'm sorry about that. So when we talk about strategy for initial management of COPD, pharmacological strategy, a couple things. The GOLD 2023 report supports more aggressive initial bronchodilator therapy. So for group A, this is group A right here. The minute you're right here, they're saying, yeah, single agent long-acting bronchodilator right off the bat. If you're in group B, time to use dual long-acting bronchodilators, a LABA-LAMA combo right up front. And you could tell when you go back a couple slides over here that in the beginning, if it was just, hey, let's just use a short-acting by itself and really start using long-actings right when you get to moderate. But no, we're going to use long-acting up front right away, and we're also going to use dual long-acting bronchodilators the minute you're going to be a group B. And definitely when you talk about group B, you should be on a dual long-acting bronchodilator. And then if you're still having or high risk for exacerbations, definitely we're going to add that inhaled glucocorticoid. If you're not and you're stable, we might not add the inhaled glucocorticoid in those cases. So with that being said, let's do a couple questions. 62-year-old man is evaluated in follow-up examination for COPD. Despite smoking cessation, adherence to his medical regimen, good inhaler TIG, and participation in pulmonary rehab, he continues to experience breathlessness and mild exertion and has diminished quality of life. He has a minimal dry cough. He has never required treatment for an acute COPD exacerbation, which is good. Meds are triple drug, fluticasone, umclenimide. Oh, these names have to stop. That's a LAMA, and Valanterol, which is a LABA, and use albuterol as needed. Immunizations are up to date on exam. Vital signs are normal. O2 stats 93 with the patient breathing room air. Breath sounds are slightly diminished. 6-minute walk shows a minimum oxygen saturation of 91% with the patient breathing ambient air. Spirometry shows an FEV1 of 36% predicted, a DLCO of 41% predicted. Chest imaging shows upper low predominant emphysema. Which of the following is the most appropriate therapy? Well, this person's maxed out on drug therapy, already went to pulmonary rehab, and still is having symptoms. So, do you think we should do long-term azithromycin therapy? He's not really having a lot of exacerbations. So when we talk about medications for exacerbations, that's either going to be A or C. C is roflumilast, goes by the brand name Daliresp. And if the other option will be giving azithromycin. Of course, check for the QT interval, and always worry about, resistance and pre-selecting resistance to gram-positives. I don't think A and C are the right answer. Supplemental oxygen, he doesn't meet the characteristics or the criteria, to choose a better word, for supplemental oxygen just yet. There has to be a reason why they talked about upper low predominant emphysema. This would be someone that you would consider doing a consult and talking about lung volume reduction surgery. So lung volume reduction surgery, we'll talk about it, improves quality of life. It improves exercise tolerance. There's survival in selective patients who have upper low predominant disease, or one of them was more damaged than the other. Usually we like the FEV1 and DLCO to be greater than 20% of predicted and higher. These patients benefit if they have a low exercise tolerance after they finish pulmonary rehab. But of course, it's surgery, and that's what makes it really tough. And one of the things that we do instead of offering these patients surgery is, think about what they call endobronchial therapy, where you could kind of collapse the lung from the inside. So to go back to lung volume reduction surgery, if anyone doesn't really comprehend or it's kind of fuzzy, why would someone do this? Well, it's because if you have that really damaged lung, in the upper lobes, one worse than the other, if you chop it off, it's going to actually literally chop it off. It's going to get better VQ matching. Of course, there are side effects when you do these things. But the other thing they said, there's something called endobronchial valve therapy, where you place these one-way valves in the area of the lungs that have that, really bad area, and it will kind of induce atelectasis. So it's kind of like doing lung volume reduction surgery, but minimally invasive. But, for, endobronchial therapy, though it's FDA approved, they don't have the mortality data just yet. I'm sure they'll eventually get it, but that's a minimally invasive alternative to lung volume reduction surgery, which in select patients do have mortality benefit. So with that being said, I want to say a couple of statements about, the role of CT. The GOLD 2023 guidelines are actually pro getting a CT in stable patients with COPD for certain reasons. If there's someone who has frequent exacerbations, excessive coughing, sputum production, maybe getting that CT to look for bronchiectasis. Maybe they need some airway clearance over there, Look at this. Maybe they can't be a candidate for lung volume reduction surgery. And here's going to be a classic CT over here where the right lung is much worse than the left, even though both lungs are horrible. We said if they're upper low predominant, one lung worse than the left. But look at one of my bullet points here. You can also consider a CT for endobronchial valve therapy, But there's a very special protocol you need to do for that. You should talk to your interventional pulmonologist. And just yet, there hasn't been any survival benefit from doing this, which I'm sure it will. And last, of course, it's unfortunate people with COPD, high risk for lung cancer. So maybe getting that CT in terms of getting your annual low dose CT for lung cancer screening in certain patients. So when to add an inhaled corticosteroid to long-acting bronchodilators. The GOLD 2023 gave us some guidance with this, which I thought was really, really nice. So these are factors to consider when adding the ICS to long-acting bronchodilators. What strongly favors the use of an inhaled corticosteroid if you're having lots of hospitalizations and exacerbations for COPD. No questions asked. if you're having more than 2 moderate exacerbations of COPD per year, if you're going to have blood eosinophils are greater than 300 cells, So maybe because there's an asthma component there, that's going to be a strong part of it. That's why the next line said, history of asthma or combined with asthma. But, eosinophils in itself have shown that it story correlates with the effectiveness of having inhaled corticosteroids. So, interesting. Yellow, what kind of favors do you use? If you have 1 moderate COPD exacerbation per year or your blood eosinophils are somewhere between 100 and 300 cells. What goes against the use of inhaled corticosteroids? If you're having lots of pneumonias. And of course, that was one of the side effects about giving stable patients with COPD inhaled corticosteroids, putting them at high risk for pneumonia. Or if they have very low blood eosinophils, or of course, if they have a history of mycobacterium infection, like not just tuberculosis, maybe just, MAI, Mycobacterium avium complex, or intracellular. So I thought this was kind of interesting because, when we talk about COPD or any chronic disease, you always want to talk about mortality. So the GOLD 2023 has some evidence supporting things that support a reduction in mortality with both pharmacotherapy and non-pharmacotherapy. And this was very interesting. So, number one, for pharmacotherapy, there has been studies about the LABA LAMA ICS that show that, hey, it may improve survival. And there are a couple of trials out there. I'll put a picture of it in the next slide, talking about the IMPACT trial or the ETHOS trial. So very interesting. For non-pharmacological therapy, there's smoking cessation. So of course, combining different modalities, giving brand name Chantix, which is probably one of the most common things I use, thinking about, things like bupropion, combining it with nicotine replacement, combinations with cognitive behavioral therapy, reduce mortality. Pulmonary rehab has been studies that show it reduces mortality. Long-term oxygen therapy is up there. Of course, non-invasive positive pressure ventilation. People who are discharged, who are hypercapnic and hypoxic might benefit from this. And lung volume reduction surgery. You mentioned already people with upper lobe disease. Don't forget, let me mention lung transplant should be up there. And certain people with COPD can both get a single or double lung transplant. And because I was so surprised about the triple inhaler therapy and mortality, I wanted to put the journal articles that we're talking about. This is the New England Journal of Medicine, the article that showed mortality benefit, triple inhaler therapy at 2 glucocorticoid doses in moderate to very severe COPD. And the other one is an article that's titled Reduction in All-Cause Mortality with Fluticasone, combined with a LABA and a LAMA in patients with chronic obstructive pulmonary disease. So yeah, this is something that's going to be a big change in how we think and how we manage COPD. So as we get close to the end, and I apologize, I'm going to probably just go an extra 5 minutes, that how do we manage COPD? Of course, making the correct diagnosis, categorizing their symptoms, their risk factors, so we can address those risk factors, getting spirometry, and repeat if it's borderline COPD. So if you go to the bottom of here, there's something called PRISM, Preserved Ratio Impaired Spirometry. And these occur when you swear this patient has COPD, they have a big smoking history, and they have a normal ratio. It's not less than 70% predicted, but the FEV1 is less than 80. So this is a terminology you may consider called PRISM, Preserved Ratio Impaired Spirometry, or just repeat it, Then after you make the diagnosis, you do your initial assessment. We talked about doing spirometry, looking at the FEV1 to being called GOLD stage 1, 2, 3, or 4. Symptoms can be categorized using one of 2 questionnaires, the CAT or the MMRC, and you want to do this along with your exacerbation history to call them GOLD stage A, B, or E, no more C and D. Always make sure they're not smoking still, you'd be surprised. Low threshold to get alpha-1 antitrypsin, especially if they have liver issues or skin issues. And of course, addressing comorbidities, whether it's obstructive sleep apnea, whether it's going to be pulmonary arterial hypertension. And that management should be smoking cessation, getting vaccines. And when I say vaccines, make sure you're addressing things like pertussis, making sure you talk about the new pneumonia vaccine, the 20 that's going to be out there, encouraging lifestyle and exercise, thinking of things just as inhaler technique, managing comorbidities. Then from there, of course, what's going to happen in follow-up, review the symptoms, address smoking cessation. That should be over and over again, And of course, do they need oxygen now? Do they need non-invasive because they're going to be hypercapnic? If they're already maxed out on, drug therapy, do they be evaluated for lung volume reduction or lung transplant? And of course, I think that if they want to have a number, something objective of how their lungs are doing, consider spirometry at least annually in some patients. And of course, you want to adjust your pharmacotherapy and non-pharmacotherapy. So I know this is my last question because I'm looking at the time at the same while I'm giving the lecture. So let's talk about this 64-year-old man is evaluated in the ED for COPD exacerbation characterized by increased dyspnea and increased purulent sputum production. Home meds are going to be mometasone and formoterol, goes by the brand name Dulera, tiotropium, which is Spiriva, and albuterol inhalers. On exam, he's a febrile, normal intensive, tachy, and tachypnic, and O2 stat is 93% breathing oxygen at 4 liters per minute by nasal cannula. Pulmonary exam reveals diffuse wheezes on expiration, but no use of accessory muscles. The remainder of the exam is non-contributory. Arterial blood gas, pH is 7.36, PaO2 is 65. That's on 4 liters. He's hypoxic. And the PaCO2 is 43, not hypercapnic. Chest X-ray shows hyperinflation, and of course, some flattened diagrams, especially if they got a lateral view. That's when you can see the flattened diaphragms the best, but no infiltrates. Nebulized albuterol and oral azithromycin are initiated because in people with severe COPD, we do initiate antibiotics such as azithromycin. Which of the following is the most appropriate additional management? So does this patient need high flow nasal cannula? I pretty much don't think so. He's 93%, I don't think he needs high flow nasal at this time. Does this patient need to be on, kind of a bi-level device such as a BPAP? Patient's not hypercapnic, I'm sure he's not, feeling great, but he's not using accessory muscle use. So I don't think, non-invasive is the call exactly at this time. Should we do a sputum culture? You have a negative chest x-ray, you're already putting him on some antibiotics, that's kind of the guidelines when we talk about COPD exacerbation. So the only thing that really makes sense here, especially with his wheezing, that, when you hear a lot of my lectures, I always say steroids, they have, definitely benefits, but there's so many side effects. But I wanted to put a question here that says, hey, this is when you want to give steroids. So the answer here is going to be C. And the reason why I put this is because they definitely can improve a COPD exacerbation, which is what's going on here. But people always pull me aside and say, what dose? So even though, everyone's a little bit different and everyone has their personal preference of treating, for the board exams, that's what people are going to ask me. Patients with COPD exacerbation, short courses of lower dose glucocorticoids oral, such as prednisone 40 milligrams per day for 5 days, have been found to be equivalent to higher doses, longer courses, and IV administration. So everyone's different. I know that this is not everyone, and many of us will kind of default when they're in the hospital to put them on IV and higher doses. But for the board exams, what should be your go-to initial dose of steroids for COPD is prednisone 40 milligrams for a 5-day course. I really do try to stick to this as much as possible, but everyone is different. But this is definitely your go-to answer on the board exams. And with that being said, I really hope everyone enjoyed the last, 4 weeks together. I really love, teaching all this up-to-date stuff. And I really wish everyone all the best on their exams. I really can't wait to meet everyone face-to-face one day. And good luck. And I really hope you enjoy these updates. Thank you.
Thank you, Dr. Raj. Okay, it looks like we have a couple questions.
Sure.
There's one in the Q&A window and then 2 in the chat.
I'm taking the MOC in October. Does up-to-date access help in the exam? What a great question, so take it from me. I actually took my recertifications in medicine and sleep and critical care and pulm. And I got to tell you that, don't rely on UpToDate. For me, I think UpToDate was kind of a distractor. I think it kind of questions your knowledge. It kind of questions, second guesses it. There are a few times where I thought it was great. I think that there are a couple of memorizing questions where it's just kind of like, if they ask you something very specific you have to memorize, if you knew how to get there really quickly, sure. But really, the biggest thing is timing. And I felt every time you go to UpToDate, that clock keeps on ticking. And it's really annoying. Like, oh my God, where did the minutes go? And you don't get to answer the questions you really do know. So my advice is, for me, I take the whole test. Then you're allowed to have a paper or something where you could do like a race board. I kind of write the question numbers that, hey, I could probably go back and UpToDate if I have a moment. And I use up all the time. I know some people, you'll sit next to me like, wait a minute, how do they finish the test so quick? I just sit there and the questions I can't get, if I feel they're just memorizers, I do it. So I wouldn't rely on UpToDate during the MOC unless you have extra time and, there's really something that's blatantly, where it is, and it's just a memorizing question. I love that one. That was a good one. On the board, I am confused. I'm confusing roflumilast with azithromycin. If presented in the answer to pick one versus the other, which one would I pick? So they would have to give you a contraindication for one or the other. They both do the job really, really well. Roflumilast is the FDA-approved drug. Azithromycin is a commonly used antibiotic for this. I probably would say a classic one I've seen is and roflumilast really is for more people with chronic bronchitis, not really for emphysema, though we use it for both commonly. But I would say if they give both, they have to throw something like ECG stuff. So if they have a history of, cardiac disease, especially if they say the QT interval is long, you definitely would probably pick roflumilast. Or vice versa, if someone has weight issues or depression issues, I'll probably pick azithromycin. But one is not better than the other. And in some cases, clinically, I do have patients on both. Can you go figure that, So they would have to give you side effects for one to choose the other. Great question over there. I joined late, but I wanted to hear about the use of antihistamines in asthma or COPD. And, when we talk about asthma in itself, antihistamines are not really the mainstay therapy for allergic asthma. I think that they are good for allergies, and of course, many people with allergies have asthma. But when you talk about the dogma of core things we use for, asthma therapy, with the assumption we're referring to allergic asthma, it really comes down to inhaled glucocorticoids, which is such a big part of using those inhaled glucocorticoids, as your as needed and your maintenance together. So it's not wrong to give antihistamines, but that's not one of the core things that I think about in our pure asthmatics. There may even be a better role of those in mast cell activation syndrome in certain cases. Same thing with COPD. Why can't someone who smokes have allergies? So you definitely can use antihistamines, but they're not part of the core thing that we use, the dogma of drugs that we use to treat people with COPD. Great question. Thank you, Dr. Raj, for sharing your knowledge and time. Thank you both for whoever said that. It really makes my day. Thank you, Dr. Raj, so much. Great pleasure. She attended all of them. That just, oh my God, one of the best things I've ever read. And I think I got all of them, everyone.